Welcome to the Jewish Study Center. I'm Jerry Garfinkel. I am the treasurer, as well as the tech director of the Jewish Study Center. As treasurer, I want to tell you that our classes our Zoom classes at least, are all free. Our Latka Humantash and debate, we charge a food fee. But we do have expenses, and so we encourage people to make donations. If you want to make a donation, go to our website, www.jewishstudycenter.org. Click on donate, and then you can donate from your PayPal account or from your credit card. If you do credit card, it'll go through PayPal, but they won't record what you're doing. They'll just process your credit card, or by check. And if you say check, it'll give you the address to send it. As you probably realize, this session is being recorded. After the class is over, I will upload the recording to YouTube, send an email to everyone with the link to where the recording is. Meanwhile, everybody is muted, but we do want your questions and your comments. So if you have questions or comments, please put them in the chat box. Address them to everyone, because sometimes you have a question, someone else may answer your question. So I think that's about it. Oh, and also the closed captions are on. So if you can't understand my accent or Banana's accent or whatever, you can look at the closed captions. That's my spiel for treasurer. As tech director, I guess I have to welcome you all, and I think I said everything I need to say. The next thing, though, is I'm going to introduce our Vice President, Mindy Reiser, and she in turn will introduce Renana, our speaker for the day. So, Mindy, will you please say your piece?
Hi, everyone. I am talking in the old mode, which was radio style, where you won't see me, but hopefully you'll hear me. I'm delighted to introduce Renana, and you're in for a really fascinating discussion with her. Okay, Dr. Renana Brooks is a clinical psychologist, political consultant, and senior clinical student whose career spans the intersections of mental health, spiritual leadership, and public discourse. She is the founder and clinical director of the Summit Institute here in Washington, where she has maintained a psychotherapy practice since 1990. Dr. Brooks consults nationally on political communication, and she specializes in power dynamics and in framing strategies, and has advised multiple presidential and gubernatorial campaigns. Renana holds a PhD in clinical psychology from George Washington University here in Washington, and previously served as an adjunct to the clinical faculty in the Department of Psychiatry at Harvard Medical School. She completed her residency at Harvard-affiliated hospitals and pursued further training in mindfulness, family therapy, and integrative health. As part of her spiritual path, Dr. Brooks is a senior in the rabbinical ordination program at the Academy of Jewish Religion and completed a clinical pastoral education program at the Hebrew Home for the Aged. Her writings on politics and psychology have appeared in The Nation, and she continues to be a sought-after voice on issues of emotional engagement and persuasion and healing, both in the therapy room and in the public square. Further ado, Dr. Renana.
Okay, so I wanted to start out by telling you why I how I got interested in this topic. Um, I encountered when my husband had a sudden heart attack. I hadn't, I really didn't expect it, so I hadn't really, he hadn't updated his will, and I hadn't really thought about all the issues. I found the doctors coming to me and asking all these choices, all these questions.
Renata, you're muted.
Let me start again. I didn't know I was muted. Okay, so I'll start again. Um, wanted to start by saying why I got interested in this topic. And it's because my husband had a sudden heart attack. And when he was when people have a heart attack and he was unconscious, he no longer was able to express his needs. And so I, as the proxy, had to make a lot of decisions. And I felt to be honest, I had no idea how to make those decisions. I had forgotten to read the will. I mean, the advance directive. It was written 30, 40 years ago, and I just felt the questions the doctors were asking, I just didn't have a great answer. Certainly not based on Jewish tradition and thinking. And I love theories because they really organize things. So I wanted to get back. This workshop is going to be in two parts, and I wanted to get back. I mean, I wanted to start out by let's just get to the basic principles, which will be the start, and then let's build out from them an understanding of Jewish texts and really get to the core of how do you start to think about the values as represented in the text, and then in particular, I wanted to approach the issue of how guilt about people who make decisions, which we have to do for the ones that are gone, and to say it, really understand what it if you really understand why you're having to make the decisions and what the criteria on, I'm hoping that people will feel a lot less guilt and will be able to uh, understand that they made the best decision, or they're making the best decisions they can, and that will be comforting in some way. So that's the structure of this workshop. I'm going to speak about what bioethics is and how it's an ethical trade-off between competing values, and that there's no perfect decision, but we're trying to make a thoughtful decision. I'm going to get at who decides. American laws may be clearer than Jewish law, but there's lots of discretion within the law to listen to other people's opinions. And I'll get in. Today, we're doing the more theoretical pieces of this course, but later on, in that part two, we're going to get really practical and go through autonomy and all the decisions and treatment choices and that you make. So, and as I said before, my hope is that people will feel much better. See, why is it not moving? I'm trying to, oh, there you go. Okay. So the question is, as I mentioned a second ago, what is bioethics? So, the name implies bio and ethics. So it's ethical choices about health-related matters. And as I said, there's no clear right or answer, but ethics kind of, you're seeing a balanced scale there. What we're trying to do is balance the scales and sort of think through how do we balance them? What are our principles? What are our values? How do we let go of the fact that some of these choices are hard? So I could do a whole course really on Jewish versus general bioethics. By general, I mean American. Maybe that's not the best way to call it general, but we keep in mind that we are governed by American law, and even within Judaism, we are governed by American law. I think we all probably know that American law is very autonomy centered. You really want to get at what is the will of the person. And most of the cases I'm going to talk about, at least today, from the founding, are not. They're not the cases where somebody's been dying for a long time, or you have lots of time to think about it. I'm looking at mostly the ethics around emergency kind of decisions. When you have new information, not when you just have a do not resuscitate order and you're just letting somebody go and everything is predictable. So in those cases, and in the cases I'm talking about, or focusing, at least in this first part of the workshop, autonomy is, the person is, let's say, unconscious or for some reason unable to express their will. So we're talking about who represents that person's autonomy. In your advance directive, which we'll talk about later, you obviously, hopefully, assuming you've take the heat, one of the warnings from this talk is to really think about and talk through your advance directive. But hopefully the person has picked the person who's their proxy. And so that person presumably reflects their will. I'm going to get into cases later in part 2 where anytime you get into cases, you see it's a little bit more complicated than that, because people have emotional and psychological issues, particularly spouses, and some, are they really representing the autonomy? But according to American law, we just presume that you designated somebody as your proxy, and that is that's our best guess about who is representing your will. Beneficence and maleficence, those are a little more complicated to get at, and we'll talk a little bit more. But beneficence in American ethics is only do good, make sure you have the goodwill or the good intention of the person who's, in this case, the patient, in mind. And malfeasance is not to do anything that would be just destroying that person. Now we're going to talk a lot about those factors, but just to sort of keep an umbrella in thinking about Jewish bioethics and the room you have to follow Jewish. And again, I'm going to put a little caveat here, because Jewish bioethics, there's a huge range. I'm going to focus because I think I know my audience, I'm going to focus on the range of Jewish bioethics that's from the more halakhic, the more halakhic, but conservative point of view to the liberal end. I'm not going to touch anything more halakhic or more, whatever term you want to use, not anything more orthodox, because we don't have room to discuss that. So in this realm and in the original text, autonomy is valued but not absolute. What do I mean by that? We respect very much the will of the person, but there also is a sense, and we can talk about what we mean by God, but that the life doesn't entirely belong to you. It's a shared partnership. So, for example, you're not supposed to, and in American law, autonomy is supreme, but in Jewish law, autonomy is valued, but it's not absolute. You're not allowed to refuse treatment. And so if we look at beneficence, we're trying to somehow in Jewish bioethics get as close as we can to autonomy and towards healing for the person's benefit. And we'll get into that, but not to interfere with the dying process. So then we have the first text that I want to go through. It's a case of Rabbi Yehuda Hanassi. Now, Rabbi Yehuda Hanassi was the prince of the Mishnah. He's the very big, one of the biggest figures. So when he was terminally ill, the rabbis said, nobody wanted him to die. I mean, nobody wants anybody to die, but particularly the rabbis declared a fast day, and all the students were praying like crazy for him. And at first that seemed like a really good idea. It's respectful. But then the maidservant noticed that he was having a lot of pain and agony when he tried to put on tefillin. So she dropped a pot or a jar to interrupt the prayers of the students. So when the noise happened, she dropped out. She interrupted their prayer. And if we think of prayer in this example, we're talking about looking at prayer as like medicine. So she stopped essentially the medicine, because with a figure as great as Rabbi Yehuda Hanassi, the rabbis assumed that this would be saving his life. And so that she disrupted them. So that was removing an obstacle to his death. You can see the modern analogy to that. That's discontinuing a ventilator or stopping life support. So now we're talking about, let's infer from that the basic principles. We have pekuach nefesh, which is an saving of a life. And we have permitting natural death, removing impediments when death is near. So if we go back to the original thing, we've got to find some balance between these two competing values. That's and we're trying to find at any moment the right balance. So there's some things that are very clear from Jewish tradition in thinking through how we're going to find this balance, and every person is going to have a different balance. So and we'll get into this because there's always a little loophole or innovation or way to look at things that gives you more latitude or less latitude. So I'm going to mostly try to get you to be able to think in terms of what worldviews best fit your model. So, this is a general principle that Jewish tradition prohibits actions that hasten death, but it's just one principle that we're going to weigh against others. So don't take it too literally. So one of the things, at the same time, we are not required to prolong suffering. And I think we're all familiar with the sort of proof text that comes from this, from Kohelet, a time to be born and a time to die. So modern medicine must distinguish between care and interference. Oof, don't do that. Okay, I'm trying to move the switch. Okay. Sorry, modern technology. Okay. Dorf. So now we start thinking about, and this is I think this would be true in American medicine too. We're going to talk about the effective versus beneficial treatment. That's how we have to think about this. Now, effective, if you take an antibiotic and it works, it's effective. But is it beneficial? Is it a good idea? We're thinking in the realm of a patient, and we'll get into what realms we're talking about. But if we're talking about a terminal patient, is it beneficial to cure them of that infection? Maybe that's a nice way to die given certain circumstances, and we'll talk about that. So you really, and I forgot to tell you who Dorff is. So I'm going to refer to a few thinkers. Dorff is, I think, is from JT, Jewish Theological Seminary. You've written 200 articles on halachic innovations, and he's really very. I don't know if many of you know the laws of widows, of abandoned women, when it's been very difficult for them to remarry. But they came up with this concept of guna, that somebody who's been abandoned, uh, there's a special innovative way to make sure that they can remarry. So this is what Dorff is very good at. He's going to think humanistically, and he's going to find some innovative way to look at text that might not be the way that I mean, if we talk about the Talmud, there's always an innovative way to read it. But basically, he's innovating and showing us an interesting twist, reading a text in a way that allows for more liberal ways of looking at things. Um, um, so one of the innovations that he's done that's very, very interesting to me, and I think really, really helps us, and shows us a surprising flexibility in the halachic literature, is a concept. It's called treifa. It's taken from animals, uh, and don't let that throw you too much. But in the Gemara, it has to do with the idea of how much damages should you pay if you inadvertently kill an animal, let's say. And later on, it'll apply a little bit more to people. And so for a treifa, an animal that's terminal in the sense that they have, let's say, it's sort of like the hospice criteria. It's less than a year to live. So this concept of treifa means that if you're within a year of dying, roughly, now these, then it's not as, you shouldn't ethically think of it as killings, let it, I don't like to use the word killing. You shouldn't think of it on the same moral level as if you let someone die by withdrawing treatment. You should feel more at peace with the fact that this person might have to die. So the classic case of treifa is if Jews are not allowed to think of the quality of life, and they're not allowed to say my life, my life is worth more than somebody else's life because I have or the reverse. If a parent says, I want to sacrifice my life for my child's life, we're not supposed to evaluate the quality of life. But in the case of treifa, right, if let's say you were surrounded by enemy, and they said, we'll let everybody live if you give one person up to die. In this special category, you're allowed to do that because you can say that their life is less like dying than other people's lives. So, Elliot Dorff uses this innovation of the treifa to say we are not obligated to preserve life that only prolongs suffering. It's not, if we want to think there's a realm of life and there's a realm of death, we've kind of crossed over a little bit into the realm of death, or a lot, and it's no longer a question of terminating life. It's just prolonging suffering. So we have categories of prolonging life, that every moment of life might matter, but you're not living life if you're in the realm of dying. So it's not just biological life that we're thinking about. Okay, so then the rabbis go in and they try to really flesh out this idea of that that that's respecting the death process as natural and allowing the soul to depart from the body. Because that's when that happens, that's what death is in Judaism. So this is a distinction that they make in the Shulchan Aruch. It's a little nuance, but we can't hasten death, but we may remove things that unnaturally prevent it. Now you could think about this in the in the ancient texts. They didn't obviously talk about ventilators, but I look at this and I see ventilators. But the example they use is that if there is salt, I don't know, this is what they thought, salt under the tongue preserve life for a time. You could remove things that are just barriers to what you would normally expect to happen. Okay. And then so we're going back and repeating this idea because it's such an important way now that we've understood the concept of treifa. You can see that it's taking off that burden of prolonging life at all costs. And you have to figure out exactly how to word this, but we're not killing a fully living person. It's not, and I think even saying the word killing is a problematic, because we're not killing, we're allowing somebody that really has passed into the realm of dying. We're not stopping that. That's quite different than that's quite different than holding on your shoulders the burden of. I mean, some people, the word killing there is very provocative. It's really about accepting the status of this person, that they've already entered into the death realm, and beginning to think, which is a very hard thing to do, but allowing them to go through that process. And this allows space to prioritize comfort and spiritual care. So you're not so focused on it. Now, the text that Dorff uses, again, this treifa concept. So in Gemara Yoma, they talk about this concept. It's called Chaya Sha'ah. And that means that like one flickering second of life is important. And when you're rescuing people, or we know this, and also when you're rescuing hostages, for example, we have that feeling that 1 second of life, we're going to do anything to try to save somebody. But that's really in the context of saving people. It's not in the context of illness. So in Avodah Zarah Gemara, and it requires a little twisting to get this, but we learn, in contrast to the Gemara Yoma, that we really don't need to preserve fleeting life, that it's a risk-benefit analysis. This Gemara is a context that we're not very comfortable with, but it's talking about whether you can people that are not in your Jewish community, whether you can trust them to save you. So it's really about taking risk. And it says you needn't go to if you're trying to save your life, you needn't go to great extremes and great risks in order to save your life. So you only look at the value of fleeting life when you're in the living realm. When you're in the dead realm, you don't do that. And I also already went through the beneficial versus the effective criteria. You can save a limb. And when we get into the cases next week, we will see how important thinking about treatment of beneficial versus effective is. Sometimes, from a psychologist's point of view, you get very carried away with wanting to save a life, and you don't think about beneficial versus effective. You really just, some people feel emotionally, this person's going to survive, and put everything into it. So this is an extremely important criteria that's often, for the decision maker, very hard to do. So then we want to find a place in understanding pain and the patient's perspective, because some people say that they really don't care about pain, they just want to live. But it is important to realize they may have said that at some point in their life and may not feel it they may not have known what kind of pain they're going to go through, but you have to think through how the patient himself would think. Okay. So one of the interesting things in the tradition is that there's a huge difference between withdrawing. Well, I should preface it. I don't want to say there's a huge difference. I personally don't see that much difference between withdrawing treatment once it's started, because I think in emergency situations, you don't have any information about what the outcome is going to be. So we really don't want an ethical system that's going to say, if you start treatment, too bad for you. In Israel, for example, they have ventilators with timers on them. And they do that so that people won't get into this ethical quandary, which they may be imposing on themselves. But if they start treatment, it's going to be too either halakhically or emotionally difficult to stop it. Once the ventilator is on, it's going to be very hard to remove it. So one of the concepts which I don't like as much as the TREFAs, the law of gnosis. And gnosis, I think we all have seen this or if you've seen dying, what happens with gnosis is that let's say within 3 days, but again, there's a lot of disagreement about what that means. But within some period of dying, the signs of dying are very clear. There's tossing and turning, there's a certain rigidity, there's a certain, you can feel it in your bones that somebody's about to die. And as timing, the Talmud talks about 3 days, but it's obviously not that exact. So this is the text, which sort of says, you can't, this concept has been used by some to say you can't do anything to hasten life, like giving a lot of morphine. To hasten death, like giving a lot of morphine, because a gnosis is alive in every respect. So anyone who, and they sometimes the Shulchan Aruch or the Talmud speaks in very dramatic terms to make a point. So they say anyone touches them is considered as if they have shed blood, like a flickering candle. One touches it, it goes out. But this is really talking about a very specific situation. It's not it's not a principle that's going to hold through everything. Okay. So how do we think then about withholding treatment? How do we ethically weigh these things out? And I did touch on this before, but I'm going to go back to it because I think I believe this is probably one of the toughest areas to think about. So as I said before, there's this concept of even brief moments of life are valued and preserved. Now, that's in the context of living. They don't talk about, again, at what cost. But there are limits on preservation. We know from Leviticus that the text says you shall live by the commandments. Notice the word live, not die by the commandments. Life preservation is not absolute. And there is a law that you're supposed to be willing to die in order not to commit murder, not to commit idolatry or incest. There are lots of other cases. So there are lots of other cases too about martyrology or King Saul taking his own life in order to protect the dignity of the kingdom. So there clearly are situations where you're not supposed to take a life, I'm sorry, the opposite, where there are cases where you do obviously allow people to die. So it's not absolute. And as I said, the Avodah Zarah Gemara has been interpreted as showing that those situations are when there's no benefit for the patient. Now, benefit is different from no cure, but benefit means if you look at what I consider life, if you look about what the meaning of my life is, that it is not good for me, as best as your proxy can understand it, for me to live. And we know in American law, you can refuse treatment quite easily, but even in Jewish law, you can ethically refuse treatment, even if it shortens life, if the burden is too great. Now, you will again have to figure out as the proxy what that means. All right. So we're going through here then. I'm going to show you in a bit some advanced directives that spell out broad philosophical definitions of what are all these choices, starting with the big broad view of what are the core principles and going all the way down to individual choices that we're going to consider next week. Things like whether you want to have a ventilator, whether you want to have antibiotics, whether you want to have hydration. So these, as an example that I'm going to show you, in the conservative movement, they produced an advanced directive where the choice between Reisner and Dorff. Fred Reisner is a conservative rabbi. Also, it has all the same credentials as Dorff, but he's a little bit more to the right. So the will actually says, I see with each ethical choice, I go more with Reisner, I go more with Dorff. And you could do that for the reform movement, or you could do it with your own liberal values. You could just lay out what all these choices mean in your advanced directive. So Reisner prioritizes reverence for life. He forbids any act that may hasten death, including morphine, if used to that end. That's a little problematic in practice because it's a medical decision how much morphine you use. But he would, in theory, say you can give morphine, but you have to be very careful that it doesn't hasten the ending of a life. But of course, even he is trying to say that patient suffering cannot justify withholding treatment. So Dorff, I mentioned before, has that concept of treifa. So he really wants to drive in the point that withholding or removing treatment in really tough cases is not murder, but compassionate care. So then we have the CCA R, which is reform, and it emphasizes individual autonomy and dignity. So you have compassionate reasoning and quality of life decisions. And that is really, that is the realm, I would say, that American doctors ask quite a bit. They ask you, would life be worth, doctors in my husband's case, for example, said they have had patients that said, if I had to, I love music, let's say, if I had to live without a violin or without being able to move my arms, it wouldn't be living. Or people that say, I can't, if I can't walk, that to me is not living. So the CCAR would be much more in line with the American notion that we have a right to determine that the person has a right to make a proxy that will focus on individual autonomy and dignity. So all of this is to embodied in your advance directive in your choices. And we're going to preview some of this for next week. So you can be, I'm going to give people a case to think about, and then if there's time, we'll do other cases. We want to sort of talk in small, depending on how many people and how we're set up, we're going to talk about what are these big philosophical and halakhic and textual understandings mean when I get down to making decisions. We're going to sort of case it out and decide, in this case, when would I be able to stop measures and with what consequences? So these big differences that you can look at when you're, Jerry's going to include it, the directive in the Google Docs that you could all study. But these differences affect, in particular, who makes the decision, whether it's more your written will or more the people that you think can infer your decision, because no one really can cover all cases. And, there are all these close calls. So you really have to decide whether people should infer from the written thing or from the people who are close to you and how they decide. It's going to go to such issues as, can pain relief hasten death to be compassionate? Can treatment be withdrawn and not just withheld? Okay. And then I'm going to briefly show the advance directive, but in a minute before, but first I think I mentioned this to you all, that I'm going to, for your reflection, have you look at this case. It's, and really think about these principles, or you could think about your own case, but sometimes it's nice to think about somebody else's case. So, but just so we can think about what difference does it make in practicality, these decisions. And as I said, you could see how nice it is for your family members to know what your will is by really being thoughtful in your advance directive. I will tell you that even after my husband's death, when I filled out my advance directive, I really didn't think about how much it mattered. And I really still could have done a lot more thinking about what it means to, to live with diminished functioning and what really matters in terms of my quality of life. How am I making that decision? So that's what we're going to do next week. So this is look at time. This is the advance directive, which is in your packet. And you can see that so the way that they're laying this out is that everybody, and by everybody, they mean everybody that is interested in the conservative movement's way of looking at things. it is my wish that all prudent medical treatment should be extended to me with the aim of affecting my recovery. Should that be deemed impossible, then it lists out nutrition, which would be considered like food and hydration, medication, and necessary surgical procedures should be continued when they are understood to be effective measures for extending my life. Medical knowledge, however, may find itself at a loss as to which form of treatment is best for me, or whether a given treatment will be helpful or harmful. In such circumstances, I would want a course of action that protects me from unnecessary pain. So everybody would, according to the conservative movement thinkers, would agree with that. But then the second opinion is Rabbi Dorf's opinion. And you see this difference. It is my wish that all prudent medical treatment should be extended to me with the aim of affecting my recovery. Should that be deemed impossible, I want those caring for me to act for my benefit, interpreting that value in light of the choices I have made and any other knowledge you have of me. There's that inference. In some cases in which I am terminally ill or permanently unconscious, choices to withhold, that means like turning off the ventilator or stop life-sustaining treatment, may be consistent with my wishes and my understanding of Jewish teachings. So I'm open. There's a lot more choices there, but I'm open. I'm gonna in a minute be open for questions. I am available if people would like to ask any questions after the class. I'm not somebody who will give you definitive readings, because you can see it's so individual and it depends on your belief set thing. But I will be happy to share articles or different ways of looking at this. So people can write to me. It's just my name, renatabrooks@gmail.com. Or between sessions, you can write and say any case, specific times of case. Next week is the real practical hands-on. So if there are particular cases you would like to discuss. But right now we're open to any question of any sort. And I'll hand that over to you guys.
Okay, so Mindy will be managing the Q&A session. Thank you, Renata. Mindy, are you on?
I'm on.
Okay.
Okay, folks. We have several observations.
Hey, wait. Renata, could you stop your screen
Very
sharing?
good idea. Sorry.
Yeah, let me keep you on though as a spotlight. Okay. Okay, Mindy, go on, please.
Okay. Well, we do have a number of observations in the chat, and people should put in other questions or thoughts. Right now, we have a bit of time. So let me start with an interesting question. People who are indicating they couldn't live without the loss of a function, and Renata talked about people who live for playing their violin or other things that they must do, otherwise life isn't worth living. So, discontinue the treatment, and then they realize that they want to continue living. Any guidance there from our wise people or interventions you know about?
Well, first of all, the thing is, and this is the really tough part, I'm focusing for the most part on people who cannot express their will right at this point. So you really have to make the decision for the person. Now, I actually, with my husband, I used nonverbal signaling. If I had him, raise his finger to indicate his will. So we are, unfortunately, the law is I think even from the Jewish and the American law, it's very clear, and this is why you want to fill out an advance directive. It is, we're trying to figure out what that person wanted. Now, if they can tell us what they wanted, or they can, you know, uh, then we'll feel we have to comfort ourselves that we're making the best decision possible. And, if somebody's changing their mind, unless you can figure out some way where they could signal you, I'm talking about cases where people's will is unclear. The other real problem is that we don't really, let's say somebody says brain functioning is what really matters to me. We're not that accurate always in knowing what that means. The tests aren't that clear. You can, the TCD test, for example, blood flow, it's not necessarily going to predict for us exactly whether a person can play the violin, right? So you have to forgive yourself for making the best possible decision. And I mean, even the patient themselves, there's some of these texts that I uh, talked about risk and benefit. When you do treatment, you don't know if it's going to work. You don't know if it's going to have risky side effects. Sometimes there are surgeries you go in and it may work, or it may leave you more brain damages. So we really have to comfort ourselves that we're making, it's not our decision, first of all. It is the person, we are guessing what that person would have wanted, our loved one would have wanted. So you really have to comfort yourself. I would say that's my best advice. And just say, you don't know. And if a person changes their mind, how would you know? Unless they can communicate with you. Okay, next.
All right, we have a question that many of us will confront, and some of us may be already confronting, and that has to do with Alzheimer's. And
Uh,
any insight, Renana, in terms of working with Alzheimer's patients, and if they haven't left statements of their wishes, how to deal with that? And Alzheimer's people come in and out of consciousness and rest and thinking. So where do we go there?
okay, so here's the thing. I mean, that's a fascinating ethical question. I think we have to trust the representative to really understand the person that they're representing. Now, that's actually not accurate because their own psychological needs will interfere. But I think, I mean, if they came into more lucid understanding, you could talk to them even for a moment and get a better sense of what they wanted. You have to put yourself in the best to say, this is my best estimate of what they would want. And Alzheimer's, in a way, is an easier case because uh, the illness comes slowly. So you have time to really discuss. It's not a pleasant task, but you have time to say, uh, what are your thoughts about Alzheimer's? How do you want to live? What state is going to be too much for you? Um, this is something that there's no, I don't want to say there's no excuse, but this is a case where it should hit you over the head that it's the right thing to get a directive and to really you know, have these kind of tough discussions with people. Uh, it's not a pleasant thing to say how you're going to feel, when people are worried of it. I didn't talk about this that much, but people feel very bad talking about quality of life issues because it seems to them that like they're communicating, gee, I don't want to deal with your problems and it's not worth it to me. But for to deal with you when you have problems. But really it's a very compassionate thing to sit down and say, I hate to talk about this, but I really want to know how you feel, because eventually I'm not going to be able to talk to you and know how you feel. And I really want to know, what does it feel like? What do you think you're going to feel like? And you can keep checking it as long as the person can communicate with you to see if the person has changed their mind. My father, for example, uh, when he was younger, he said, I want you to put every measure, because he'd never been sick. He said, I want you to use every measure known to mankind to prolong my life. Um, then when he was a vegetable at 96, I don't know, my years are a little off, but let's say it was about 96. Um, right before he went into that state, my sister asked him the question, do you still feel like you did before, when he was afraid that he was about to go into a vegetable state, but he hadn't yet done it. But the prognosis was clear. She said, you still feel that way, that you want to be alive at any cost. That he said, did I say that? you know, that's what I think happens. We don't discuss this because it's scary, so we don't update the wishes. But I think you have to have that conversation periodically. And I imagine, it hasn't been studied, but I imagine the older you get and the more towards the end, that your idea of, when you're 50, you probably say any measure possible. Also, I don't think I emphasize this enough. The big distinction is whether something's treatable or it's not treatable. So diseases that are progressive clearly are not treatable. So that is again another easing of saying to yourself, maybe the measures are, I wouldn't personally feel bound, uh, uh, you know, by the written directive. I felt in the case of my husband that I knew that his wishes would evolve over time. And uh, I thought maybe his advance directive overstated how great it would be to fight for your life. So you have to put yourself in somebody's positions if you didn't talk, but I would suggest that the best way to do it would be to talk. Okay. Good question. Very interesting question.
Yeah, well, we're touching on some really emotionally charged issues, and it's really important that we're getting this on the table, Renana.
Yeah.
And I think this will resonate importantly in people's thinking. All right, somebody here talks about something I'm not familiar with, and I don't think many of us are, and that is MAID. And the person, Erin, asked, what does the movement think about MAID? But what's MAID?
Yeah, unmute and tell us what MAID is.
Anybody know?
Can you raise your hand and maybe I'll be able to see who it is.
Or put it in the chat who you are.
Well, it's in the chat already, but the
Antonia
description.
Bookbinder.
Okay.
So unmute her.
You can unmute yourself.
Hi there. MAID is medical assistance in dying. So
Oh, yes.
Oregon, places like that.
Mhm.
I just pulled up a chart on the number. In 2016, there were a little over 1,000 MAID deaths. In 2023, there were 15.3 thousand deaths.
In Canada.
In Canada. Using MAID. So that's I know that it's gotten a lot more traction in Canada than it has here.
Well, I'll say a couple things about that. I when I studied the laws of abortion, I was amazed that for me that the Jewish tradition was much more liberal than I thought. And again, when we say tradition, I'm talking about certain range of views. So I think there's a little bit more room than we might think for assistance in dying, depending on who you're talking about. Because we know, for example, and I talked about this text at the beginning, King Saul. There's a reverence for life, but there's certain situations where life is intolerable. King Saul did it to protect the dignity of the kingdom. So I think there are some situations, I think if it's the first distinction we would have to make when we talk about MAID is this a treatable disease? I think pretty much no one would agree with it if from, to the left to the right, if it's a treatable disease. And also they probably wouldn't nobody would buy it if it was a young child, probably. I mean, there's certain cases that are off the table, but I think when we're talking about absolutely intractable and unbearable life, we certainly are consistent with avoiding, not requiring any kind of treatment. And I think there's room to, I mean, if we have time, we could even look at a case because I have some interesting articles on that. I don't think it's 100% ruled out, but most halakhic, most people, at least Dorf and, from the side of Dorf and on, would say it is written. It is not consistent with Jewish ethics, but I think you can find a place to explain where you might understand it to the more liberal to that. If we have time, we can, in week 2, we can go into that more.
Okay, another fascinating question by Lisa Schwartz. What people haven't said where they are in the world, so that might be fun to know. But Lisa poses the question, what if there are differences of opinion between, say, 2 prophets, and you have parents of a child who have different positions on what should be done? Perhaps there's a divorce or a separation, and each person thinks a little bit differently. Maybe there's room for compromise, maybe there isn't. Do you have any thoughts on that?
Well, for Lisa's question, are we talking about American law or because if it's American law, it would be a court that would decide who gets to decide, assuming a dysfunctional situation. And probably if there's a lot of conflict, the courts, the doctors will probably, I mean, we had that in the Quinlan case. Probably the doctors are going to go on the side of being very conservative because they're afraid to be sued. Now, what Jewish law probably would say is people should be reasonable and think about the best interest of the child and not fight, but that's not practical. But I think that the American law would trump any Jewish law in that situation because people wouldn't touch it.
Hey, another rather fascinating issue about cremation. And any thoughts within the Jewish tradition on that? And getting that right, talks about her preferring to have she wants to be present for her kids on a shelf rather than in the ground. And that's sort of forcefully said. So any thoughts there?
Well, I mean, cremation is not traditionally accepted in Judaism, but it's kind of a different issue than we're focusing on because it's really about what is death and what does it mean to be dead. We don't place a whole lot of autonomy in Judaism classically once a person is dead. It's because the autonomy comes in making the decisions about whether to fight to preserve life. In the realm of dying, the it's not a whole lot of time spent worrying about people's autonomy and decisions. Uh, we did have one friend who planned her funeral before she died, so she would have autonomy in the ceremony. And we do believe in general, and these are big statements, but we do believe that the person's soul hovers around, uh, after they die. So not a lot of thought is put about how to respect the autonomy of the person at that time. But it is interesting that that would be a wonderful thing to respect.
Okay. Alan Kersey asked an interesting question, which I guess you could interpret in various ways. He asks about the complexity of mercy.
Of what?
Slosh at the complexity of mercy.
What a beautiful phrase.
I
Yeah,
guess he probably means mercy,
let's
a lot of mercy.
unmute him to let him say what he means, because he's a very thoughtful person.
Alan, you want to raise your hand so I can find you?
Complexity of mercy. Well, I
Oh,
think,
there is Alan. Okay.
yeah, okay, go ahead. You want to ask your question, Alan?
And
Okay. So this goes to, and you're familiar with this. It took 3 weeks for Rhonda to die. She became more or less unconscious after a couple of days. And they were giving her, this is at hospice. They were giving her morphine continuously. And she'd go in and out of some level of consciousness. And we would call the nurses. I mean, she would come out of what would appear to be totally unconscious, and she'd moan. She seemed to be in pain, and then give her morphine, and then she'd calm down. And what struck me is, and made me very depressed, was that during those periods where she was becoming sort of slightly conscious, and she seemed to be expressing pain, whether she was having 3 weeks of unimaginable nightmares. I mean, her brain was dying because it was brain cancer, and whether we were actually prolonging a really long nightmare by doing this. I mean, obviously, when they give her enough morphine, morphine is that I'm a biologist, but morphine's like typical anesthesia in that, as far as we know, the brain activity doesn't form images or anything else, but it was going in and out. It was wearing off. And during that period, she just seemed to be in pain, and it was very distressing. And so, that to me was the complexity of mercy. We're trying to reduce her pain during that period, but it was extended and it was not complete. It wasn't all the time. And what was going on when it wasn't there? And that's, I found
I
that.
will tell you that I think the entire part 2 workshop next week is about the complexity of mercy.
Okay.
Because I think, and some of what we said today, because you're balancing, I mean, if you're asking, should we do things to hasten death? Is that what you're asking? Or are you
Well,
asking?
I mean, the thing that struck me was that, and I mean, I remember my daughter sitting next to her bed and crying her eyes out, begging her mother to give up, because the sense we have was that there was a lot of residual suffering, and that in a sense, by, giving the morphine, sort of prolonging it. But I mean, obviously,
I mean, so morphine isn't really generally considered to prolong suffering.
no, it's not that.
Yeah.
It's that you're allowing her to take her time to die,
Yeah.
by periodically suppressing pain. What would be the alternative is what you discussed a few minutes ago, which is basically you give her enough morphine so it's all over, right? She doesn't
Yeah.
come out. So
Well,
that
I'll say this.
you reduce suffering, which wasn't like 3 weeks of suffering.
Yeah.
I mean,
I mean, we're working, first of all, within the American law system.
yeah,
Uh,
no, it couldn't be done in Maryland. I
yeah,
know.
there are no doctors that are going to do that.
No, it couldn't be done in Maryland, but it could have been done in Oregon, for instance. And then we would have to decide, is that the best way? So
Yeah.
it's still a philosophical issue, and it's a philosophical issue within Judaism in terms of what we think the moral issues are, or how we should face them when we're dealing with someone we love.
Yes,
That's
absolutely. I'm with you, and that's I am actually focusing on those kind of issues next week, because I wanted to lay out the big framework, which is, is this to the benefit of the patient, and should we do things to hasten death because it's unbearable?
yeah.
And it's not gonna, you're certainly gonna have to go very left in your analysis, or liberal, to get someone who's going to understand what you're talking about. But I don't think there's no room to see it.
Okay, now,
Let's turn to a final question, which is relevant to the news and events some of us have been watching with regard to Pope Francis. And Betty Sinowitz asked, did the Pope make the best decision to continue extreme treatment, even though the treatments he believes were painful and in the end did not help? Do you have any thoughts on this, Renata?
So again, any autonomous person is ethically allowed to go through whatever suffering they want to go through, because they believe that living is, or even dying, there's a very interesting Gemara where the rabbi students were around him when the Romans were trying to burn people down, and they said, the student said, "Why don't you withdraw your bandages, Rabbi?" And he said, "No, I don't want to hasten death. I want to have every moment of this meaningful experience of dying." He didn't say it that way. He didn't give his rationale, but if the Pope, it's certainly ethical if somebody wants to prolong their own suffering and thinks that even one moment of their life is better than not being alive. You know, that the real questions come if somebody was the proxy of the Pope, would they be able to do that? What is Lisa saying? I'm thinking of.
Okay.
Yeah.
All right, Renana, this has covered a fascinating array of questions with
Yeah.
much to think about, really. And I know next week there'll be more to discuss and ponder. Do you have any final thoughts for today you'd like to share and have people think about over the next week?
Well, I think that is the question. When we hit gray areas, what is our understanding and our way of conceptualizing what we do about it? Are we, I mean, one response is to say, I don't really care what Jewish thinkers think. I'm going to do what I think is right. And there's probably room for that. So what I would like to focus on is trying to go back to the big principles that I laid out here. We're always trying to balance, honoring death and stopping to prolong suffering. I like the idea of thinking, like with Alan's case, that when you enter the realm of dying, when it's clear that the person is dying, that we stop thinking about that as trying to prolong life, that we really accept that we're in the dying process. And then we can start thinking about how do we want to manage that. It's very hard to infer psychologically what the state of the person is when they're going through this. And it's important to take some comfort. You know, the Jewish ethics don't talk about this, but there are a lot of cases of people who have died and come back. And while they were very scared of the process of going through the death, it should be of some comfort that when they came back, they weren't too scared of going through it. If we see it as a journey, doesn't mean we don't want to stop them from suffering, but it should take a little comfort that maybe on this journey, once they get to the other side, they won't feel as bad about it. But these are not going to be easy choices. I think what we have to hold on to and preserve for ourselves is that you're trying, you don't always know what the will of the person is. You're trying to come as close to it as possible. You can't control all the factors. You certainly can't control the doctors who have a bias towards preserving life at all times. You have to, all of these decisions are made on our best guess of what the medical data is. And we really don't know very much what the medical data is often. Sometimes we do. And so I think the biggest message I have is let's find some way to comfort ourselves that we're making the best decisions we can. And to be at peace about that and realize it's not exactly your decision.
Renata, I can't let this last question go because it would bring in to the discussion your thought as a psychologist who's dealt with people in all kinds of ways. And the question is of a man, Daniel Kahneman, who went to Switzerland to die by assisted suicide. The person writes when he was 90, even though he was lucid and did not suffer from a terminal disease. So that's someone choosing to commit assisted suicide. And how would the Jewish tradition look at that?
Well, I'll start off by saying some people think life is a terminal illness. And we are all going to die someday. I think they'd be a little skeptical that simply aging was a terminal disease. And if he went there, so here's what I would say. I always look for loopholes. If he wanted to, why did he want to die by assisted suicide? Something was deeply troubling him. He was afraid of aging or, I think that the tradition would be more sympathetic if he was suffering, if he said, I'm 90, I'm afraid of aging, I'm afraid of losing my mind, I'm starting. But this case, as the facts are presented, there's no way that the tradition would say, oh, that's fine. They do have a vested interest in saying life is worth living. Now, you balance that. Ethics is about balancing it. So you balance it by saying, okay, life is worth living, but not if it's full of suffering. But you're not describing suffering here. He just didn't want to, unless you fill this in by saying if he wanted to die, he was probably terrified of death. He was probably starting to get depressed by it. You'd have to fill in something to begin a balancing process. But I'm a little dubious of this case winning. I don't think it will win an argument, but it is fascinating.
Well, again, this has been an absolutely fascinating and riveting discussion that touches us all, immediately or ultimately. So let me turn back to Jerry, and he'll remind us next week and any further comments you'd like to make.
Okay. Oh, the light is terrible over here. Okay. For next week, we'll have the second session. So your registration for this session is also good for next session. You don't have to register again. And at one point, Renata, you mentioned a packet of things for the students. I assume you mean the documents that we uploaded into a folder and gave people the link to that folder.
Yeah.
Okay.
I also
Um,
want to comment on the chat from Linda. So getting back to Lisa's case, he wanted to die on his terms when he could still make the decision, which Switzerland allows for. She didn't ask whether I personally agreed. I'm, I understand his decision, but I don't think that the rabbis or the classical Jewish tradition would understand his decision. I think they would be, I was really answering for them. I think they would require some pain or suffering and to weigh against what life has to offer. Now, it is true over time, for some people, as you're aging and facing aging, the value of what life has to offer may go down. So it's a less tough choice. But I really think if you're going to try to make an ethical argument, you have got to make the case for what is the problem and the pain and the suffering, And so you have to weigh these two factors. You can't, as I said at the beginning of the talk, and this is why we go back to the original principles, autonomy is in the Jewish and way of looking at things is not absolute. So this is a case that Linda was talking about where autonomy is king, and autonomy in as I'm presenting it is not king. There are it might be really, really, really important, but it is tempered by some factors, and you have to say what those factors are.
Okay. Someone is asking, when is the next session? I just said that. The next session is a week from today, same time. How do you copy the chat? I don't. If you give me an email later, and I'll send you whatever you want from the chat.
And I will say something to Jerry's point too, just as we close. It said that case in Switzerland, he chose to keep his pain private. An ethical decision is it's what a person, it's the factors that are weighed against each other. So the ethicality doesn't depend on whether it's been communicated. So the person's pain being private, the question is whether we would judge his decision to be ethical or not. And we don't have enough information to make any mitigation against the idea that life is important to live in that case. It doesn't mean that his decision is unethical. It means we can't figure it out. But we can only decide based on the facts of the case that are given to us.
Okay, we'll call it close now.
Yeah.
I plan to upload the recording to YouTube. I've had some problems with my computer for the last 15, 20 minutes. I'm not sure whether the recording is going to work out for the entire class or not.
And for anybody who asks, some people ask for my email. It's very easy. It's my name, Renana, and my last name, Brooks, @gmail.com.
Well, if you're giving out your email, we can put it into that email that I send out about the recording. Anyway, if anybody have other questions they want from me or from Renata, just email to one of us. I will have Renata's email, I guess, in the link I send to people, and you can also send, write to me at Jewish Study Center jewishcenter@gmail.com. Okay, so I hope to see all of you next week.
Yes.
And thank you again, Renata. And we'll see you also next week, Renata.
Okay, great. Thank you.
Okay.
Hey, good night, everyone.
Night,
and
everybody.
glad you could be with us.
Bye-bye.